Great, wonderful. So I'm just keeping all these things. Those who have any queries, doubt, query, concern, questions, they can feel free to ask me very quickly. I'm going through the introductions. We are medical MCQ for all, providing all study material, book, website, coaching, short package, mobile applications, dedicated mock test. I'm Dr. Munjal Pandya. I'm hemato-oncologist and transplant fellow, and I've been practicing for more than 20 years and good clinical experience and academic as well. Dr. Aarti is our consultant pediatrician, taking regular lectures of pediatrics daily. Dr. Maddie, Dr. Shikha now shifted to Dubai as well with Aster downtown Dubai. So those who are in Dubai, you can meet and greet Shikha as well. Dr. Ankit is a consultant gastroenterologist as well, and there are long list of the team. Our number, our hard copy book, right? Various packages, discounted rates as well. So those who wants to join, they can join. Very nice. And Anjali will come today evening as well for meeting. So you can come, you can have any queries regarding data flow, documentation, exam booking, license transfer, blah blah. Anjali will guide you. And as you know, we are planning to launch by probably next Saturday or Sunday, 28 or 29. I'll keep you updated in the group. Emory residency we are about to launch, and let's start our mock test. So first questions in front of your screen. Concentrate well on the questions. Today is excellent questions and very knowledgeable as well. So which of the following tests can assess the risk or indicate the prognosis for the heart in the acute coronary syndrome? CKMB, myoglobulin, troponin, CK isoforms, or CK index. So what is the best? What indicates the prognosis? Prognosis means something by knowing which you know that okay how the disease is going to behave down the line, good or bad, right? So which indicates the prognosis, right? So you post your answer in the chat box, then we will discuss these questions in detail, right? And I wish everyone post the answer because many a times I'm seeing that most of the peoples are inactive. So consider that this is your exam. Think in that way. If the same question comes in your exam, how you gonna react to these questions, right? Forget about right, wrong, what is that? Don't worry, right? Just try to answer, try to understand the questions, right? So CKMB, yes, Dania. So I'll start with you. What do you understand by CKMB? Yeah, we'll start our discussion. We'll open our discussion now. Yeah, so some people are saying CKMB, some are saying troponin, some saying CK index. So yes, Dania, if you can able to now interact with me, you can open up your mic and discuss. So what do you mean by
Yes, sir.
CKMB?
Doctor,
Sorry.
yes, sir. This is a creatinine kinase. It's a creatinine kinase. It's a fraction. Is usually diagnostic for
So what is the full
acute
form of
coronary.
CKMB? First of all, what is full of form of CKMB?
It's creatinine kinase.
So what stands for MB? So if you don't know, that is your homework. Go and get the full form of CKMB. Now, fine, no problem. So why you selected? What do you understand by prognosis in CKMB? So say for example, one patient of acute coronary syndrome or acute myocardial infarction or ischemic heart disease, all are same thing. So this patient comes to you, right? What you gonna do for this patient? You are doing CKMB is a good marker, troponin is a good marker,
Prop-
remove all the other options. So, what do
Troponin.
you think? What could be the main prognostic
If the
value?
troponin, sir, the
Troponin.
troponin is positive, then we'll go for CKMB, the cardiac enzyme, because it will show us that how long, because it releases by the muscles. So it will
Both
tell us that
released by the myocardial muscle. Both released by the myocardial muscle. But what they are asking, what right can assess the risk? Who is more risky, troponin or CK? And number two is what indicates the prognosis. What is highest sensitive and specific as well, right? So altogether, what right? So if you have a choice of doing one test among this list, what test you will do for this patient in acute MI? You have only one option that okay fine, you do only one test out of this five tests. What test you gonna do? Yes, Dr. Sapna Rani, what you would like to do? You can open up your mic, Sapna Rani. Dr. Antara, any idea? See, discuss. Don't worry about right or wrong. Discuss, na. I am doing this much of effort on Sunday out of the country, right? I am sitting in front of the computer with full 100% dedication. So you must also have some dedication, na. You otherwise, without dedication, you cannot crack the exam. It is not very simple exam. I don't want to give you the pink picture. I don't want to give you the good, this answer which makes you happy. It's a little tricky exam, and they are making little more tougher and tougher day by day. So you need to know everything, each and everything, not just this MCQ. You know all five questions. What is this? Yes, Pooja, Priyanka, any option, any answer? I will ask today each and everybody. I am preparing
So
this lecture since
troponin,
day after yesterday. Yes, tell me. What do you take, Pooja or
is it
Priyanka?
troponin?
Troponin. So what is troponin? Now tell me, what is troponin? We are
It
doctors,
is
we are
a
not a nurse. We need to know basic things. Yes, troponin is what, from where it release, how many days it will release, at what time it will go peak, at what time it will go down. Yes, Radhika, you want to comment anything? Tell me. I'll give opportunity to each and everybody today. I'm not at all in hurry today. And I never be in hurry because it's a learning platform. Until and unless you use your brain, you will not have a good score in the exam. You must have to read very sincerely. Yes, Radhika, any comment?
So I'm not sure. I'm just saying. I think the CKMB enzyme it rises first and it stays elevated for a long time. Uh, that is why it's
But they are
used
not
to
asking, they
indicate
are
the
not
prognosis.
asking, yeah, so they are not asking about who rise first and who rise down and who goes down early fast. They are asking about the risk or indicate the prognosis in acute coronary syndrome. So presence of what? Right, so answer here is a troponin. Let me tell you, right, there are lots of interesting facts about troponin. So troponin, right, troponin, there are two component, troponin T and troponin I, as well as CKMB, right? So I had given the homework somebody to find out the name of MB. You told creatinine kinase, but what stands for MB? It's your homework. You go and open and read the book, right? Don't just sit on the Sunday, you read it sincerely, right? So this is what the thing is. So see, this is the literature. So comparative efficacy of cardiac biomarker. So first of all, see, somebody told myoglobulin. So myoglobulin is absolutely non-sensitive and it should not be the answer at all, right? Myoglobulin, it's a learning platform. So I will discuss each and every point, right? So say for example, acute coronary syndrome, or if you're I mean thinking that somebody has acute myocardial infarction, STEMI, non-STEMI, whatever, what would be the first test? What would be the first test? Then first test is ECG or EKG, electrocardiogram. You should not miss the EKG or ECG. Any chest pain patient is means it should be ECG. Any chest pain means ECG, right? Any chest pain means ECG. So don't, right? And it is honestly speaking, it is underutilized. It is underutilized, right? You need to utilize well ECG, right? We are underutilizing. Any chest pain, even at the 18 years of boy comes to your OPD and emergency room, 18 years. Even I can say 16 years. So we are not thinking of 16 years boy with acute myocardial infarction. But you never miss this because out of 1,000, 10,000 patients, you have one patient. Out of 10,000 patients, you have one patient who has age of 18. He has acute MI and he died. We are seeing every day in the newspaper, na, young people dancing in the party, dancing in the marriage, dancing in the reception. We see lots of reels and video. They die. They die because of cardiac attack. They die because of acute MI. They die because of some ventricular flutter fibrillation. You never know. Right. So never ever write down in your note chest pain is equal to ECG. Even if they give classical history of GERD, gastroesophageal reflux disease, muscular disease, whatever disease, right? They whatever hypertension, stress, tension, whatever. Any patient in your OPD, if they tell, sir, I have a chest pain, that means it ECG. And if you follow this rule, I'm telling you this after, I mean, experience of my 20-25 years of clinical experience. I'm telling you. So don't underutilize the ECG. Any patient, anybody, male, female, elder, diabetic, non-diabetic, risk factor, no risk factor, obese, black, white, any religion, race, anything. Chest pain is equal to ECG. Write down. If you follow this rule, you will save hundreds of lives in your lifetime. Till you are practicing, you save hundreds of people because you know the basic principle. Chest pain is equal to ECG. If ECG is normal, that's fine, no problem. Why you are worried that oh ECG is normal? So don't worry, don't stress. But if you miss something, right, in chest pain and somebody will die, you will be blamed badly. And sometimes it's a medico legal issue, right, everywhere across the globe, right, medico, because chest pain, you miss the chest pain, you miss the heart attack, patient died, it's a big trouble. You cannot imagine how much big trouble to your practice in future and for your license. So chest pain is equal to ECG. This is how I follow in my practice, right? I am a though oncologist, but if somebody patient comes to me, right, and telling me, sir, I have chest pain. Okay, fine, go into the emergency room, get the ECG in 2 minutes, show me the ECG, right? I'll discuss with cardiologist, 5 minutes, it's all okay. No, no cardiac disease, it's fine. So first and foremost is the ECG. So don't skip the this chain, right? So first is ECG. ECG, what it is written, time to become abnormal, time at the onset of pain. So at the onset of immediately, so immediately, so nothing is faster than the ECG, nothing is faster, no enzyme, no nothing, no trop ti, anything, whatever, nothing is faster than ECG. So immediately, yeah, so see, this is the book word, this is from Master the Body, it is not my slide, right? It is from the standard international books. So immediately at the onset of, they become abnormal. So what is the most important thing? Any patient comes to you, ECG take. That's it. What you are going to look into it. There are two things you want to see. What you don't want to miss. This all related questions. Don't think that this is a one question related with the prognosis. Whatever, if you listen me, there are 10 questions in it, there are 20 questions which may comes in your exam, right? So this is not just we are discussing one question, I am trying to give you the concept. So once you did the ECG, there are three possibility: either this ECG is absolutely normal, or this ECG, first second most step for you is to see the ST elevated or non ST elevated. That's it. So if ST elevation, it is a more bad prognosis than non ST. So if I can tell you one exam answer, that Mr. John in your OPD comes with a STEMI and Mr. Matthew come in your OPD with non-STEMI, to whom you attend first. STEMI. STEMI has high mortality. Untreated STEMI, if you don't treat a STEMI, right, in few minutes, there are high risk of mortality around 40 to 60%. They die immediately, right? And this percentage is less, right? Because non-STEMI, still there is a flow in the blood in the coronary. Still there is a flow in coronary. Here 100% coronary is blocked. 100% coronary is blocked, and that is why you get a STEMI. It's a, we call it as a massive MI. Massive MI is usually STEMI, right? Non-STEMI, still there is a flow. This is a coronary artery, right? So what is 100%? This is 100%. This is 100%, 100%. Blood cannot flow from this side to this side because it is completely closed here. This is STEMI. And non-STEMI, what happens? This is coronary artery. This is this, that. It is blocked, but still there is a 20%, 30% perfusion is there which supply the muscle of the heart. So when the muscle of the heart are dying, there are two enzymes released in the blood, troponin and CKMB, that we'll see now. So this is the primary pathophysiology of acute coronary syndrome. So you need to understand. You don't need to mug up. So we have a three entity when you do the ECG. Okay, normal, it's fine. It's ST elevation, ST depression, non-STEMI. You attend the first STEMI, right? That does not mean that you should not concentrate on non-STEMI. But if they ask you in the exam, right, which one is a bad one, right? Which is prognostically bad? STEMI, non-STEMI, unstable angina, stable angina. What's the answer? STEMI is the answer. That's it. So we'll move on the next things, ST elevation, right, which will eventually progress to Q wave, right? So this is the normal ECG. As you know, this is P, Q is very small, then R, S, right, baseline, and this is T, right? This is the P is atrial activity, QRS is a ventricular activity. So anything you want to see, ventricular tachycardia, ventricular flutter, left ventricular hypertrophy, anything related with the ventricle is a QRS complex. Simple, basic. Anything wrong with atrial flutter, atrial fibrillation, premature atrial contraction, this is all P wave. So when something is wrong in the atria, it's a P wave. Something wrong in the ventricle, it's a QRS. You go and attend and see our Madis lecture of ECG exclusively on our YouTube channel, right? Those who have not seen, so you get lots of clarity in your mind. Those who does not have, just drop me message, but try to do some exercise and open up the this YouTube channel. Medical MCQ for all is on YouTube channel. It's there. Anyway, so this is what the thing is. So what we are discussing here, right? So we are discussing here that it's a ECG, right? So ECG is the first, right? Now see why the myoglobin. Somebody has given the answer myoglobin. So when the myoglobin is answered, there are three various questions. In one question, there are three questions. Let me tell all the questions because you never know what questions comes in exam. No, they will not ask as per my coaching and teaching. No, they ask for their things, right? So you need to know everything, right? So one question is this: if they ask in myocardial infarction or MI, which protein get first elevated in the plasma? First, number one, answer is myoglobin. Answer is myoglobin. We'll discuss then why we are not doing. We'll discuss that. But if they are why myoglobin, see within 1 hour, within 1 hour. This is both are 4 hours. So 1 hour is earlier than 4 hours, obviously. So myoglobin is elevated first in the plasma. Acute MI myoglobin is elevated. Second thing, right? Troponin troponin, and CKMB. So, say for example, acute myocardial infarction within 1 hour, they're going to start. So, if the patient has a myocardial infarction at 12 o'clock in the noon, and you are doing at that, a patient comes in the OPD at 12 o'clock and 5, within 5 minutes, is very next to the hospital, next door to the hospital, the patient is living. Within 5 minutes, is in the ER. You are doing ECG, you are doing a trop T, trop I, CKMB, everything is normal. Everything is normal. You say, oh, it is not a chest pain, it's a muscular is a god, you go ahead, go home and don't worry. Never ever tell this, don't worry, in a chest pain patient. Never ever tell. Remove this word from your dictionary, don't worry. No doctor should use any word like this, don't worry. Because there are matter of concern. That is why they are in the hospital. Na? Why you are giving the false assurance to the patient, don't worry, right? So first do the ECG when there is a chest pain is ECG and troponin I, troponin T, myoglobin, whatever, everything is negative within 1 hour. Nothing comes before 1 hour in the plasma positive, nothing. And patient is came within 5 minutes, is next to your hospital. He has chest pain, he immediately came to hospital. You are saying, oh, don't worry. And 1 o'clock after 1 hour, he has acute massive MI and he died because of ventricular fibrillation. Why? Because you send them home that okay, go to home, don't worry, nothing to worry. Your troponin, TIC can be myoglobin, all normal. It's not a cardiac injury, it's not a myocardial infarction. You go home. Keep this patient under the observation. Any patient suspected, I have seen many patients, those who have normal ECG in early stage, right? But in within 2 hours, they develop massive MI. They have anterior septal MI, V1, V2, V3, V4, all elevated very badly. Trop I after 2 hours, trop I 4 hours, right? So don't give false assurance, right? So this is what the story is. So if you have any doubt, if patient is a classical obese, hypertensive, diabetic, elderly, more than 50, family history, even though ECG is normal, even though his troponin I is normal, keep them under observation for 12 hours. If the classical history of acute MI and ECG and enzyme both normal, ECG and enzyme both normal even, keep them under observation for 12 hours, and every 1 to 2 hourly you should do the ECG. Every 1 to 2 hour you do the ECG and you do the enzyme, troponin and CKMB. That's it. If they are not developing anything in 12 hours, there are extremely rare chance that they have MI. What you are thinking. That is why you keep them under observation. So within 12 hours, nothing happens, let them go home, right? But if you are in doubt, even though ECG and enzymes are normal, don't give the false assurance that, okay, gentlemen, don't worry, you go home, nothing wrong, he will die in next 4 hours at home. Even he will not get the time to reach to the hospital, even though he's 5 minutes away, because ventricular fibrillation means it's collapse. The leading cause of death in MI is not because of coronary blockage, it is because of the arrhythmia. And arrhythmia, worst arrhythmia amongst all the arrhythmia is a ventricular fibrillation, is the worst. Nothing more worse than ventricular fibrillation. So they will die because of this. So that you must know, right? So ECG is the first, as we told, right? Then myoglobin is never answer. The reason behind myoglobin is it is a non-specific. Why? Because myoglobin will increase in a skeletal muscle injury, it is increase in myositis, it is in muscular injury, right? It is increase in many neuromuscular disorder, it increase in septicemia, it increase in the DIC, it increase in many conditions. And because of atorvastatin, statin, many drugs also can cause myositis and increase. So it is a non-specific. It increase does not mean that it's like increasing ESR. Can anyone tell me What is the diagnosis of increased ESR? Your ESR should be 1 to 10. Now your ESR is 100. Anyone in the house can tell me what is the diagnosis of 100 ESR? Anyone? I want someone to comment on this. Normal range of ESR is 1 to 10. If I do your patient's ESR and ESR is 100, what is the diagnosis? Tell me.
It shows the chronic illness.
Right. Can you name the disease? One disease. Is there any one disease or long list of disease?
Yeah, long
Malignancy.
list of like
Long list of
rheumatoid
long
arthritis or
long list. So you just
Tuberculosis.
yeah, so there are long list: tuberculosis, any infection, any inflammation, malignancy, right? And in malignancy is my main area of interest for last 20 years, right? So whenever I academically interest, I do ESR. There are a lot of patient increase in the ESR. So you just Google it once or read it from book. What are the differential diagnosis of ESR? There are 100 diagnoses where ESR is raised. What does it mean? It's a non-specific. It is not diagnosed to any specific disease. The myoglobin is same thing. Myoglobin is not diagnosed. Raised myoglobin means what? There are hundreds of diseases where myoglobin will raise, right? So it will give the suspicious, but it's not diagnosis for anything. ESR high, you are suspecting tuberculosis, right? Being a physician, but I suspect multiple myeloma, role formation and high ESR more than 150. I've seen in hundreds of patients in last 20 years. So it could be tuberculosis, it could be multiple myeloma, it could be rheumatoid arthritis, it could be mixed connective tissue disorder, right? So there are lots of things which happens, right? So you need to know. So myoglobin is not the answer. Now you have tailored to two things, troponin or this. So troponin is the most highest sensitive and specific. So troponin is the answer. So one question, so which protein elevate in the plasma first after myocardial infarction? Answer is myoglobulin, but it is not sensitive and specific. So look at the question, what exactly they are asking, you need to answer on that. So you need to keep very close eye on the questions what they are asking in exam. So if they are asking which protein or which enzyme elevated first, myoglobin. Second thing, prognostically which is more important, then answer is troponin, right? Second thing, which enzyme will tell you about the relapse or restenosis. So one patient comes to you OPD, right? Another scenario I'll give you in the context with this only, right? And what is that another scenario? Another scenario is that one patient admitted today, right? One patient admitted today in the hospital, right? This is all questions related with your MI, so your MI will be fine. So one patient
How does
admitted today,
troponin relate to
22nd
prognosis of
September
MI?
patient. Yeah, 1 minute. I'll get back to you, sir. So 22nd patient admitted, right? Patient diagnosed as acute MI, right? Is troponin I and CKMB both are elevated with ST segment elevation in the ECG, right? Now patient you had given the thrombolytic, right? Patient is fine. After 6 days, say for example 27 or 28 day, again patient is telling I have a chest pain. You had given thrombolytic. ECG is improving on 23rd, 24, 25, 26, 27. ECG is showing the signs of reperfusion. ST elevation is going down. Probably, you are seeing some Q waves as well, right? Or at least, the patient is improving clinically. But again, after 6, 7, 8 days, 28, 29, 30 is saying the chest pain. Then which test is more important? CKMB is more important or troponin I is more important? CKMB is
CKMB.
more important. CKMB, exactly, CKMB.
CKMD.
Yeah, CKMB. The reason why CKMB, I'll tell you the reason. So CKMB is started rising in 4 to 6 hours and it will remain in the plasma for 1 to 2 days only. So what happened? 22nd CKMB is positive, but 25th, if you do the CKMB, it is negative or it is within normal range. Again on the 28th, if it is rising, that means again some myocardial infarction, myocardial insult is there, and in that case, CKMB is again raised. So for what happened in a recurrent MI, right? Recurrent or again the things in, right? So recurrent MI, what happens, right? So CKMB raised, right, in 1 to 4 hours. It gets elevated for 1 to 2 days, and then after 3 days, it becomes normal. Again, fifth day, if it is elevated, means it is a recurrent. Again restenosis, again reinfarct, you can say. right? In a different way, reinfarct. So this is all happens. So this is all related with the questions related with the enzymes. So now you go and read all the enzyme. I told you as it is, I mean, as per the book, but still you need to revise it. Otherwise, you will forget after 1 2 days, right? So the easy point I'll give you how to remember it, right? So you will remember better. So see, this is right. So three different answer for one questions, right? ECG is always the
Sir,
first. Earliest, yes.
sir, but troponin also lasts for 10 to 14 days. So why
Yes.
not troponin? It's
Why not
mentioned here.
troponin? Yeah, why not troponin? Why not troponin for reinfarct? We are talking about reinfarction, right? We are talking about
Yes.
reinfarction. So why not, right? So simple logic, 22nd patient admitted, right? And 14 days, say for maximum 14 days, right? So how much is the 14 days? So up to
4th,
4 or 5th of the October, example,
4th
roughly,
of
right?
next month.
So it will be elevated, troponin, elevated up to this. So how did you get to know, right? It is elevated here, it is elevated here. So how do you differentiate that it is a new MI or it is a recurrent MI or it is old MI? This is old MI or this is recurrent MI. Here it is also elevated, here also elevated. But CKMB is what happens. CKMB here elevated. After 2 days it is normal. Again it is get elevated. Means something new event happens. After normalization, something new
Okay.
event will happen. Here no normalization. It's elevated, elevated. Here the level is 10. Here is also level is 10. How did you get to know whether it is old MI or it is recurrent MI? Here what happened? It is 10, then it become
Okay.
normal 1, again it become 10. So 1 to 10, again something happened wrong. Isn't it? Yes or no?
Yes,
Yes
sir.
or
Yes,
no?
sir. Thank you.
Got
Yes,
it.
sir. Now
So
understood.
concept is clear. Yeah. So up to 14 days you cannot get it, right? Again, after 14 days of somebody comes after 1 month, then absolutely again you go for the troponin, right? Then you can know, okay, fine. After 14 days it becomes normal. But this recurrent MI usually happens in 1 to 2 weeks, 3 weeks, right? Because coronary is at damage, they are at problem. So something happens wrong is usually in 1 to 2 weeks. So here see the literature, exact literature, sensitivity and specificity. Can anyone tell me what is the definition of sensitivity and what is the definition of specificity? If you don't know the definition, you go and read. It is one of the question in epidemiology. Uh, sensitivity and specificity. Anyone wants to comment on this? I would be happy. What is the
That is,
definition or simple understanding of sensitivity? What is the simple understanding of specificity?
जहाँ से
Anyone?
स्टार्ट होता है वहां से लेना होता है,
Yes, tell
ना
me.
कि आगे से.
Anyone?
अच्छा छोड़ा.
सर आपका माइक बंद
सर,
रखो ना, मंजीत प्रीत.
एज यू टोल्ड ऑलरेडी. जी सर.
हाँ
सर
बोलिए.
एक क्वेश्चन.
ओ पेशेंट की आवाज आ रही है ना, डिस्टर्ब हो रहा है सर इसलिए.
सर जैसे, हाँ सॉरी सर. सर वो एक्चुअली आपने जैसे बोला था कि ESR इज द क्रोनिक, मतलब वो बताने के लिए है. तो सर
हम्म.
जैसे कार्डियक इवेंट है तो उसमें ESR तो रेज होगा नहीं, तो उसमें अगर CRP करवाएं तो वो पॉजिटिव मिलेगा सर.
CRP is also
एक्यूट.
non-diagnostic, not a diagnostic.
नो
It's not
नो
a
सर, नॉट फॉर
diagnostic.
डायग्नोस्टिक, बट नो, आई एम नॉट आस्किंग फॉर डायग्नोस्टिक. आई एम जस्ट
Yeah, it
आस्किंग
can raise,
इट्स
it
इफ
can
वी
raise,
आर
it
गोइंग.
can raise.
इट कैन.
CRP can raise. Any body, any infection, inflammation, CRP can be raised.
ओके सर, थैंक
Right? CRP. But again, on CRP, we will not going to take any decision, right?
यू.
We
यस यस सर.
see when you are dealing with something critical or some urgent things, your main job is what? Your main job is to find out, right? What is the most urgent critical things which kills the patient? That is the most important thing. You understand, right? So whenever the something is urgent, you need to do some test which makes patient survive, right? So if you miss ECG in MI, it's gone. You are wasting your time in doing myoglobin. You are wasting time in doing troponin. You are doing this, but you are not doing the ECG. Patient will die. So do something which is more urgent, right? So sensitivity and specificity. Anyone? No one. We are more than 25 doctors. Dr. Radia,
And
would you like to comment,
specificity
Dr.
would be
Radia?
something
Yes, please.
So sensitivity is specific to one disease.
Sorry, can you little elaborate
specificity
more
would
things?
be
I'm not convinced with your answer. Sorry. Yes, sir.
Sir,
Anyone?
can I?
Yeah, yeah. Anyone. It's a open
Sir, I
platform.
think
All. Yeah.
sensitivity is the ability of the test to find positive people
from from a positive population. That is,
Okay.
we can find the true positive from a positive people, I
Okay.
think.
So you are close
And
to the answer.
sensitive,
So yeah,
No,
sensitivity is
that will
what?
be
You
positive.
talked about
That will be
hmm,
positive predictive. Uh,
and specificity.
specificity is it is the ability to find the negative from the negative people.
Okay, wonderful. So everyone should go and read the sensitivity and specificity. It is one of the question in exam. So every word is important for us, right? So don't neglect it, right? They will ask you how to write. So in one line, if you want to understand the sensitivity and specificity, say for example, we have 100 patient, right? Patient, we have 100 patient, and out of this 100 patient, right? Five patient, right, has a positive HI positive, say for example, out of 100 HI positive. So it's the ability of the test to detect the true positive. What? True positive. What is true positive? Not false positive. True positive. So five patient is positive and test say these are the five positive. The sensitivity is 100%, right? Because five are positive and you detected five. So any test in this world is based on the sensitivity. First, the sensitivity, higher the sensitivity, it is good. Higher the sensitivity, it is good. So any test is invented across the globe, right? Any test you detect, you any test for COVID, Corona 19, COVID 19, tuberculosis, diabetes, hypertension, blah blah blah. So if the test is based because highest sensitivity one, we don't want to miss even a single patient who is positive, right? So it is a sensitivity and the test who detect the negative people who has no disease, who has no disease. So it is a true negative. So true positive, its sensitivity, true negative is a specificity. Another example for HIV, patient has HIV, right? ELISA, there is a one test named ELISA, you must have heard. Enzyme linked immunosorbent assay. Enzyme linked immunosorbent assay, it's a HIV. This is we do by ELISA method, right? Sensitivity, I can say it's 99.9%, say for example. Means still there is a 0.1% chance that you may miss the HIV by doing this test, right? And right, Western blot, you must have heard Western blot. It's a again method. Specificity is 100%, 100%, right? So sensitivity is different, right? And specificity is different. Sensitive is a true positive. Those who have disease, they find the test will find who has a disease, and it is a true negative. The test which find that these are the negative, absolutely 100% negative, it is a specificity, right? So any test who has a good sensitivity and specificity, it is the most viable test in the market. Troponin has a 100% specificity. If troponin is positive, it could be only and only MI. Here you can see sensitivity is 88%, not 100%. Means still there are 10% of the chance where CKMB is negative, but you have MI. CKMB is negative, you have MI. You cannot say, oh, CKMB is negative because 88% sensitivity means out of 100% of acute MI, 88% or 90% can detect it that, okay, CKMB is raised, but there are still 10% patient where CKMB is not raised. You say it is not myocardial infarction, go home and don't tell go home. Still there are chances. So 100% sensitive. So those who have acute myocardial infarction, 100% it will find that troponin I is elevated, and this is a sensitive, specific, and good prognostic factor. And specificity, if you see 96%, here 93%, and CKMB, right? So that's it. This is what the logic is. So you need to understand the basic things, right? You don't need to mug up just the things, right? So this is how we have to evaluate the troponin T, troponin I, and various questions related with the enzymes. All right, so I'll switch to the next questions quickly. All right, so you can revise once again. Everything I mention
Sir,
here, I
one
will share
second.
this power. Yes, please. Any question?
Sir, how do you assess the prognosis? It's part of the question. Is it
Yeah,
based on the sensitivity?
yeah, based on the sensitivity, based on the sensitivity, based on the say for
Okay, sir.
example, you did just CKMB example, right? CKMB
Okay.
CKMB is negative, say for example, right? CKMB is negative, you tell that patient, okay, you go home, you don't do anything, it's fine, everything is okay. And this patient will die because of ventricular fibrillation. So prognosis is bad, right? Because test could not pick up the
Okay.
things, and on test you are taking your decision, clinical judgment, and end of the day patient is in trouble. So troponin I is a sensitive, specific, prognostically important. If it is positive, it's not good news, it's bad news, right? So prognostically is also important, troponin I, and again the sensitivity and specificity, if they ask, it is again important. So whenever any patient comes to you, bottom line, the final is saying chest pain, you do ECG, you do CKMB, and you do a troponin as well. Why you want to do CKMB? Because if this patient comes with a recurrent MI after 7 days, you will get to know what was the baseline, how it increased, how it's normal, now again it increased. That is why you need to do. But even if you don't do the CKMB, it is good enough that you diagnose the MI, ECG, ST elevation, troponin I positive, acute MI. First line treatment is PCI. If the PCI is not available in your hospital, thrombolytic. That's it. This is what the management of acute MI as per the book. So there are hundreds of questions related here and
And
there
so
with the
one
MI.
last thing,
Yes, please.
by standard we use troponin I. So is it the
Correct.
same specificity and uh, sensitivity for troponin T, same as
Yeah,
troponin I?
yeah. Troponin T, troponin I, both same sensitivity, specificity.
It's identical.
Yes, sir.
Oh, thank you.
No problem. So now second questions in front of your screen. So if you have some acute MI questions later on, we'll discuss just to save the time, right? But this is absolutely a concept-based session. Every time we are doing the same thing, we don't need to mug up. You need to understand the things, right? That will make you win the game. So second question, 63-year-old woman present to ED emergency department, nausea, vomiting, severe abdominal pain, gradually been increasing in intensity. She states that she has not had a bowel movements in 3 days, cannot remember the last time she passed the gas. Her medical history is significant for abdominal hysterectomy. Physical examination revealed temperature of 101.5 and the hyperactive bowel sounds, and medical students thought he heard a tingling sound. Laboratory shows WBC of 15,000 per cubic millimeter. What is the most likely diagnosis? Acute appendicitis, diverticulitis, small bowel obstruction, cholecystitis, pancreatitis. Though easy, but you need to interpret the things, and I will ask each and everybody, those who are interacting, all the differential 5. I don't need just the answer. I need the differential as well. Just Dr. Priya, let's discuss with you. Dr. Priya, can you hear me? Priya Siju.
Yes,
Yes,
sir.
doctor. Yes. So now tell me, we'll discuss these questions with you, right? So what is the,
Okay.
and first of all, one second. Sorry. I am telling in each and every of my lecture every Sunday, must remember the triad.
Mm.
Any MCQ triad, 90% people knows this. Diagnosis, investigation, and treatment. So now onwards, make a habit in every questions to make a diagnosis, try to make how you investigate and how you treat. If you follow this rule, there is 100% chances of success in exam. Whatever they ask in exam, DHA, AD, MOH, forget about any exam. 100%
Mm.
my this guarantee to pass the exam. But we are not thinking in that way, just interested in answer. Diagnosis means diagnosis. After diagnosis,
Mm.
you ask yourself how you investigate and you ask yourself how you treat. So three questions in a one MCQ. So if you are doing 100 MCQ a day, means you are doing 300 MCQ a day, because you are doing diagnosis of 100, you are doing investigation of 100, and you are doing treatment of 100. Means in 100 questions, you try to solve 300 questions. This logic apply to every question. So again, we'll apply to these questions. Yes, Priya, sorry to interrupt you. Now you tell me first of all the
Mm.
diagnosis. What is the
The
diagnosis?
small bowel obstruction,
Okay,
I
small
think so.
bowel obstruction. Now tell me the point in favor of small bowel obstruction. We'll discuss a
The
lot of
history of
things and why.
abdominal, the
Diagnosis,
symptom is
the
that nausea,
small
vomiting, severe abdominal pain based on
small bowel.
symptoms.
Okay, based on symptoms. So what are the symptoms positive of small bowel obstruction in this scenario? You read the scenario and then you tell me, sir, this is in the small
Yes,
bowel
yes.
obstruction.
There is nausea,
So
vomiting,
nausea. So nausea
and
is
severe
one,
abdominal pain,
vomiting is one, severe abdominal pain. So 3 point so far. What else?
and past history of surgery.
Sir, and
Past
she
Past
history
history.
even
of
didn't pass.
surgery.
One second, one second. Past history of surgery. So how
Medical
the
history of
past
surgery.
history of surgery? Let me stop you here. Why you think past history of surgery is related with the small bowel obstruction? Is there any correlation here? The history
That's some,
with small bowel
Yeah,
obstruction.
yes, yes.
Patients.
it's a paralytic ileus, I think,
Sorry.
that may cause. This is some condition. It's called paralytic. That after the abdominal surgery, the intestines they got uh, like something. So she's unable to pass gas as well.
Yeah.
The
So what happens after hysterectomy? She has a bowel obstruction. Something went wrong in hysterectomy.
Some adhesions and
So for knowledge, any operation, any intra-abdominal operation, right, there are lots of inflammatory reaction, fibrosis, fibrous bands will create, and that may probably cause this
Mhm.
obstructions. It's a mechanical obstruction, right? Because when you remove these things, right, uterus, you remove everything, na? Uterus is like you have to completely remove the uterus from the body. That is hysterectomy, right? And they did the abdominal hysterectomy, not vaginal hysterectomy. So abdominal hysterectomy they have little manipulation with the intestine, then bowel and nearby structures
Mhm.
and viscera, right? And after hysterectomy, there is some kind of fibrosis may develop. So this is a risk factor. Any operation intra-abdominal is a risk factor for intestinal obstruction. Okay, fine. So go ahead. What else next? Right? So now there are lots of points. So now let me come to you, Priya. Now tell me why it is not appendicitis. Tell me. Now we go other way around. Why it is not appendicitis? Why it is not
It is
appendicitis?
not showing lower abdomen.
Yeah. So now, so the point against.
the,
So let me
uh,
make a list of point
so the
against this
appendix
appendicitis. So
Pain
it
is
is not in
pertaining to
the
his
lower
right
abdomen.
side.
It is not in the lower abdomen. It should be on the right side, right? Because in acute appendicitis also you have nausea, you have abdomen, you have abdominal pain. That is also seen in the acute appendicitis. Then how do you differentiate acute appendicitis? Also there is a infection, inflammation in acute appendicitis. So again there is a high count, high WBC count is also there in acute appendicitis. So how you can differentiate that? Okay, this is
sir,
not.
sir, the repness or any other test, we have to muscle guardings. We have to see the different, examination will help us in.
Yes.
And
So
there's a
so what?
particularly the right iliac pain.
Okay, great. So this acute appendicitis. So what are the point not favoring? This is make art and habit of doing this. Why not acute appendicitis? I'm giving the list of why not. I'm giving the leave why not because your job is not just to know the answer. Your job, and if you do the practice, you can answer any question because you have completely concept clear that
so the
why this and why this not. So one is age is not favoring for appendicitis. Appendicitis is usually 10 to 20 years of age. Number one, right? Not, I'm just making a list of not favoring, right? Number two is
So the
right,
bowel
it's a
movements, there were no
right,
bowel movements and no
right,
gas passed.
right, right lower abdominal pain, usually right lower right quadrant pain, right lower or right McBurney's point. Yeah, you must be knowing McBurney's point, right? Umbilicus to anterior
yes.
superior iliac spine, medial two third and lateral one third, I think, isn't it? So it is a classical, right? Bowel sounds are present until and unless it's obstructed or paralytic ileus, you cannot see the bowel sound, right? So if bowel sounds are present in acute appendicitis, or if you do the USG, there is a point tenderness is also there, right? It is not mentioned here anyway. So these points are not there. It is not less likely. It is not less likely. So age is not favoring. This is not favoring, right? And this you see the hyperactive. So right? Initially, it should be hyperactive, and then vowel sounds are completely gone, right? So acute appendicitis doesn't looks like. Why there is a no, why it is not acute diverticulitis? Again, you have to make a list. Why not acute diverticulitis? Acute diverticulitis is not because there is a usually left lower quadrant pain usually. Again, the bowel sound is also present there. There is never a hyperacute. It is an infection, diverticulitis. So what is diverticulitis? So this is a cecum. This is ascending colon, this is transverse colon, this is descending colon, and within the wall there is a diverticula. Within the wall, it is developed, and when there is an infection in the diverticulum, it is called as a diverticulitis. So classical in diverticulitis is a pain, definitely. Usually in the usually in the left lower quadrant there is a pain. Usually it's a disease of elderly people. So it's elderly people, but it is not seen much in children. So pain is there, right? Fever could also be there. Fever could also be there. But vowel sounds are normal. Vowel sounds are normal. It is not hyperactive, or there is no absence of vowel sound. And infection and counts should also go high, because it's infection. It should go high, right? So this is not fitting. Cholecystitis. Why not cholecystitis? Cholecystitis is right upper quadrant pain, right? Cholecystitis is gallbladder inflammation, infection of gallbladder just below the liver. So right upper quadrant pain, nausea, vomiting, sometimes jaundice if it is because of stone. You may have jaundice, obstruction. Yes, come in. 1 second. Yeah, so the cholecystitis is not there because of its right upper quadrant pain. Cholecystitis, the biggest two causes of cholecystitis is alcoholic cholecystitis, alcoholic, and another is a stone. So there is neither a history of alcohol, neither history of gallstone, neither there is a history of jaundice, no right upper quadrant pain, nothing matching this. And again, this 63 years age is not matching, and bowel sounds are normal. And acute pancreatitis. Why not acute pancreatitis? Acute pancreatitis is in the pain site is right. Pain site is in umbilicus or above umbilicus, epigastric rather. Specific is epigastric pain, right? Again, the history pancreatitis main cause is alcoholic pancreatitis, right? Alcoholic pancreatitis is biggest cause, and another is gallstone. When gallstones obstruct this pancreatic duct, it called pancreatitis, and this enzymes gets elevated, right? Serum amylase and lipase should get elevated.
Serum
Nothing is,
amylase, yes.
so nothing is mentioned that vowel sounds are normal, everything is fine. So doesn't looks like, so this looks like a vowel obstruction. This is how we need to make a habit, right? Why this not? Why this not? So I tell you line by line. So you must know. You yeah. So you do it in that way, right? So every questions you must think of it. So this is what the difference between small vowel and large vowel. Sorry, what's the question? Something you told? Fine. So what's the key difference features between small bowel obstruction and large bowel obstruction? The biggest difference in small bowel and large bowel is, right, abdominal discomfort or pain, possibly accompanied by visible peristalsis waves in upper and middle abdomen, and this is in the lower abdomen. Because if you see the structure, this is large bowel, this is sigmoid colon, this is rectum, right? This is a cecum, this is ascending, transverse, descending, and this is how, and in between there is a small. So small bowel, this is the upper and middle part, there is a pain, and this is in the large bowel, usually in the lower part, in lower abdominal pain. Upper and epigastric abdominal distension. When there is a bowel obstruction in small bowel, there is a upper abdomen, there is a swelling, there is a pain, there is a obstruction, there is a destruction, or sorry, distension. It's in the upper part or epigastric part. Here, the lower part. Nausea and early vomiting should be there. Nausea, vomiting in upper bowel or small bowel. Here, minimal or no, minimal or no. Usually, we don't see. What we see in a large bowel obstruction is a pain, one we see. Another is distension. Third thing is the constipation, not the vomiting. This is what in the large bowel we see. Here, the nausea, vomiting more goes in favor of small, right? And severe fluid and electrolyte imbalance, because the absorption gets placed in the small intestine. So patient who have a severe fluid and electrolyte imbalance, suspected case of small bowel obstruction. No major fluid or electrolyte imbalance. Why? Because it is everything gets absorbed beyond the large intestine or in small intestine. Metabolic alkalosis, metabolic acidosis. So anyway, this is the general, and there are a lot of things you can see. Air fluid level, right? So if you do the X-ray, right? So this is the bowel, right? So there is a air fluid level is also seen in the abdominal X-ray or chest X-ray. So you go and see it if you have not seen it, because it's a part of the exam and they ask you very frequently the X-ray of abdominal distension, air fluid level, it's intestinal obstructions. It's a very common emergency in medical science everywhere across the globe. So it's very important, right? So what is the treatment you should know, because we need to know the triad, not just the diagnosis, right? So diagnosis and investigation, as I told you, how you investigate. So diagnosis is based on the history, physical examination, and other labs, right? This is how you do diagnosis. Investigation specific, all the history is important. Along with that, you do the X-ray, right? And many times you can do the CT scan as well, just to diagnose and treatment. So, what is the treatment of acute intestinal or bowel obstruction treatment? Make patient NPO, nil per oral, so or nil by mouth, right? So, don't start anything orally because it's already obstructed. It will not go further. And if you keep doing it, if you keep feeding the patient, it increases the bowel pressure and there is a risk of rupture or perforation or blast, right? So don't stress the bowel when they are obstructed, right? Place the NG tube, nasogastric tube, and you do the decompression, right? Medical management, you do IV fluid electrolyte imbalance as required, and surgical decompression indicated if the complete obstruction, it's an emergency. So this is how we need to treat. Subacute obstructions usually can be treated this with conservatively. Subacute, not acute. Complete obstruction need to be decompressed as soon as possible, otherwise they may perforate. Then you have to do the laparotomy, open up the complete belly, right? So just to avoid these things, complication, and eventually it can cause peritonitis and death. So we don't need that to happen. So acute intestinal obstruction, right? Try to operate as soon as possible. Subacute, you can give a trial of this all supportive care. Wait and watch. Even after 48 hours, 72 hours, it doesn't improve or keep deteriorating, again open up. That's it. This is how we do clinically. The third question is in front of your screen. The 6 years old male, otherwise healthy, presented with 3 weeks of fever, bloody diarrhea. Examination is unremarkable. Lab shows a positive serum Yersinia IgM and stool culture growing Yersinia. What's the management? Supportive care, metronidazole, secnidazole, cipro, and oxy. Yes, Miller, what's your answer? Any comment, Miller?
Hold on. I think Dr. Cycling.
So this is your guess or you know? So what you
Yes, sir.
give in the Yersinia? Have you seen a patient, somebody suffering from Yersinia? Yes or no?
Yeah, no, right.
Sorry.
I don't
So
know.
go and get the round in your
I'll read
infectious,
about it.
probably get the Yersinia patient. Yes, Dr. Muhammad Wahra. Any comment?
Sir, Yersinia pestis, it's a it's a milk-borne infection, Yersinia pestis.
Okay. How you treat? They are asking how you treat.
Okay.
I selected today little tricky questions just to it's eye opener for many people, because few people say, oh, I knows everything, sir. I did my preparation well. Now I'm fine. So you check the score, no? End of the day, you check the score. How much is the correct answer and how much is the real answer? Then you get to know, okay, where you are standing and how to prepare well more. I'm not here trying to disappoint you. I'm just trying to make your eye open, right? You can't every time expect in 30% of the question in DHA is absolutely tricky questions. You must know it. And these all are tricky. Yes, Kanika, any comment? Any
Sir, this is Yersinia enterocolitica.
okay. Yeah, it's the
Hello, sir.
Yersinia because it's a Yersinia because they had given the diagnosis, no? Yersinia IgM and stool culture
Yeah,
for
so I get
Yersinia. Diagnosis is done. Now they are asking management or
ciprofloxacin.
treatment.
Ciprofloxacin,
Ciprofloxacin.
you will get.
Let's see what other experts are saying. We are 30 experts on Sunday. Limon, any
Yes, sir.
comment? Limon,
Sure.
Murad, Onkar, Pooja, Priyanka, Radhika.
My first
Yes, yes,
sir.
yes,
First choice
Limon.
for doxycycline and secondly ciprofloxacin.
Okay. So everyone, still there is a no correct answer. Yes, Sayyid Maria. Any comment? Fine. So consider these questions is a tricky and read it right at home. Infectious disease management is
Yes.
supportive care. Yersiniosis is associated with pseudo appendicitis syndrome with right lower quadrant pain. Relative arthritis should also be there and can follow after acute GI infections. Hereditary hemochromatosis is a risk factor. So here the answer is a supportive care. There is no anti-Yersinia so far available specific, right? So go and read it again. So this is credit questions for you. So those who have not picked the correct answer, check your score.
सर
Next
आई वाज जस्ट
questions,
सेड लाइक मैं कहने ही वाली थी सर सपोर्टिव केयर बट सीनियर बैठे हैं कुछ गलत हो गया
madam. Nothing is senior and junior in the medical field. Even junior can tell me, sir, this is the diagnosis of anemia of chronic disease, and I should not shy. So don't worry. In examination, nobody is monitoring you. Who is sitting to next to you, senior or junior? You post your answer. That's it.
Yes, sir.
That is why it's important. Na? That is why we are discussing. Na? Otherwise, I can finish it off this PowerPoint, my presentation in 15 minutes. Question 1, answer this, go ahead. Question 2, question, answer, read 3. Within 10 minutes, I can finish it off 10 slides. Na? I'm doing for years and years. But it will not help you at all.
Sir,
100% it
can you
will not.
share the slide again?
100%. You want me to go
Sir,
back?
can you share the slide again? The one you have shared right now.
This slide?
The explanation of question 3, sir, can you share the slide again?
Yes.
No, sir, the one you have explained that supportive care. Yes, sir, this one. Thank you, sir.
I will share in the group as well. Complete. Don't worry. 24 years old male with progressive fatigue. See, if you develop and cultivate the art of reading the question, everything is in the questions. Even if you don't even go for the options now, one impression will create in your brain that by this scenario, this could be the diagnosis and this could be the treatment. So you just need to see in the question what they are asking, diagnosis or treatment. That's it. Or management, right? So try to cultivate the habit of creating one impression in your brain after reading the MCQ. This is how I do personally. So any patient comes to me, right, tomorrow morning in my OPD, I'll try to compile all what is the history, what is the examination, what are the lab tests, what are the differential diagnosis. Okay, this looks like leukemia, you go and do the bone marrow. This is how I interpret, right? So go systematically. Everything is there in the scenario, but we don't bother to read the scenarios well. We are more hurry in giving the answer. What is the answer? What is the answer? Forget about the answer. You understand, and until and unless you understood question well, there are 99% chance that you end up with the wrong answer. Why? Because you did not understood the question. How you gonna give the correct answer without understanding the question? So keep your head cool and calm. Try to understand the scenario. So try to understand this scenario. It is extremely important and interesting questions, and you learn a lot of things in these questions as well. 24 years of male with progressive fatigue, intermittent dark urine, several months, evaluated for exertional dyspnea, abdominal pain, red urine, on examination afebrile, BP okay, heart rate little tachycardia, 112, SpO2 98%, scattered patachi are visible on skin, abdomen is non-distended and diffuse tenderness on palpation. Bowel sounds are normal. The remainder of the examination is normal. Lab shows hemoglobin 7. It is less. MCV 84. That is mean corpuscular volume. That is called MCV. White blood cell is 1300 per cubic millimeter. Platelet counts are 30,000 per cubic millimeter. Elevated reticulocyte count and LDH, and low or undetectable haptoglobulin. Urinalysis with 3 plus blood and no RBC sediment. Absence of CD55 and 59 on the RBC by flow cytometry. What is the management? Take your time, not in hurry. Those who wants to try, try it. Yes.
What
Nobody
steroid
wants to.
will do in hematuria?
Sorry.
What steroid will do in hematuria? It's like a
तो पहले तो मेरे को आप डायग्नोसिस बताओ. What is the diagnosis? Or what you are thinking about the diagnosis? Treatment is later on. First, we'll go with the triad. As I told you, we don't need to break the chain of triad. So, what could be the diagnosis? Possibly differential diagnosis. It doesn't mean that it's a specific 100%. So, what do you think? What the positive point? Why you want to directly give steroid? Your answer could be right, it could be wrong. But you need to know now what's the diagnosis. Without diagnosis, how? If I tell you you have one fever, how you treat? So paracetamol is simple, but I
Sir,
mean
is
you
it
need to.
leukemia?
Sorry,
Sir, is it acute leukemia? Acute
acute
leukemia,
leukemia.
is
Who
it?
told acute leukemia? So we'll learn these things. Yes, who told the acute leukemia?
Sir,
Hello.
me, Dr. Shagupta.
Yes, Dr. Sagupta. So now tell me, if you are thinking of acute leukemia, what are point positive in acute leukemia? So what do you think? What could be the positive things in acute leukemia? Tell me
Sir,
one by one.
pancytopenia. The picture of
Okay, so
pancytopenia, sir.
okay, fine. So pancytopenia is one of the things in acute leukemia. That is why you are thinking pancytopenia. What else? What more important? Because I can tell the pancytopenia can be present. This is my answer. Being a hematologist, this is my question only. So B12 deficiency, you have pancytopenia, or megaloblastic anemia, you have pancytopenia. You in acute leukemia,
Yes, sir.
definitely you have pancytopenia. Aplastic anemia, you have pancytopenia. Myelodysplastic syndrome, you have pancytopenia. Drug induced or some
Yes, sir.
septicemia have pancytopenia. So, how you differentiate acute leukemia from aplastic anemia and MDS in this scenario? Even paroxysmal nocturnal hemoglobinuria has a pancytopenia. How you differentiate? Now tell me. Sagupta, now you tell me.
Mm. Yes,
So,
sir.
just for the learning purpose, don't take it otherwise,
Mm.
learning purpose. So, your thought process is
Sir,
perfect. You think,
there will be bone marrow suppression.
yeah, so bone marrow
In sir,
suppression.
aplastic anemia, there will be bone marrow suppression. In aplastic
sir,
anemia.
sir, when the
Yeah, but still,
reticulocytes are there and they are elevated,
yeah.
so it could be
So do you think the
hemolytic
reticulous
anemia.
hemolytic anemia? So now somebody is coming up with the hemolytic. Wonderful. So see, the differential is another hemolytic anemia, right?
Mm.
Because in
Yeah, because
leukemia,
LDH.
sorry, just 1 minute. Sorry, we'll discuss. Acute leukemia, the biggest thing is not favoring this leukemia is a blast percentage. It is not mentioned. They have just mentioned the pancytopenia. So just one line. If I want to tell you today, take home message. Any patient, when you think of acute leukemia, just look at the blast only. That's it. Your eye should be on the blast. If no blast mentioned in the scenario, or blast is less than 20%, it is not acute leukemia. That's it. One line acute leukemia definition. Look at the blast. If the blast is not there, forget about leukemia. Acute leukemia, you forget about it. Is not the answer. Because definition, international definition of acute leukemia, whether it is acute myeloid leukemia or whether it is acute lymphoid leukemia, more than 20% of the blast in blood or bone marrow, mainly the bone marrow, is lymphoid origin or lymphoblast looking, it's acute leukemia, and myeloid looking more than 20% of the blast in bone marrow is acute leukemia. So when there is a no blast cell in the bone marrow, forget about acute leukemia. Sagupta, is that clear? Yes or no? Yes or no? Tell me yes or no. Yes or no,
Yes,
doctor?
sir. Clear. Thank you, sir. Yes,
Wonderful.
sir.
So
Clear.
yeah, so wonderful. So this is learning. So you got your answer. Why I'm not thinking of leukemia? Because there is no blast. No blast means no leukemia. That's it. Simple as that. Now somebody told hemolytic anemia. So now let's comes to the hemolytic anemia. Anybody wants to put your inputs? I would be great and happy to interact with each and every your queries. Right? So who told the acute?
Rhabdomyolysis.
Sorry, sir.
Rhabdomyolysis.
What's the diagnosis? Likely.
If it's rhabdomyolysis.
Rhabdomyolysis.
Yeah, right.
So how did we get to know this is rhabdomyolysis? What point favoring the rhabdomyolysis and what point not favoring the rhabdomyolysis? Tell me, sir.
Favoring the rhabdomyolysis would be the cell pain, dark colored urine,
Okay.
fatigue,
Point favoring
even
pain
the
and dark
pain.
color urine. Okay, fine. So now one question to you. In rhabdomyolysis, can you see the low HB? Can you see the low WBC? Can you see the low platelet in rhabdomyolysis? Yes or no?
No, sir.
Yes or no?
No, sir.
No, sir. So it is not a rhabdomyolysis. Simple. Dark urine can be seen in infection, dark urine can be seen in rhabdomyolysis, dark urine can be seen in some glomerulonephritis, dark urine can see, right, in paroxysmal nocturnal hemoglobinuria, cola colored urine can see in post-streptococcal glomerulonephritis, long list. So you need to know what
Okay.
happens, which is the best condition, which fits everything. And here the answer is the PNH. Let me tell you, PNH, paroxysmal nocturnal hemoglobinuria, right? So this is usually happen in a young. This is one point, young male, female, right? Progressive fatigue because of progressive anemia means low HB. Second point, because of this intravascular hemolysis and hemoglobinuria and hemoglobinuria, your urine is dark, cola color kind of things we'll see. Third thing, right? Exertional dyspnea because of anemia as well and abdominal pain, maybe because of thrombosis. We'll check it out. Pallor is because of anemia. Blood pressure is fine because of anemia. He could have tachycardia because one of the causes of tachycardia is anemia and dehydration and fever. These are the commonest across the globe. So he has anemia. Scattered petechiae. Why petechiae? Because platelets are 30,000. It could be there, visible on the skin. Abdomen is not non-distended. So you are not thinking of any obstructions or something like that. Bowel sounds are normal, so nothing wrong with the bowel, right? Examination shows pancytopenia because of hemolysis, retic count is increased, and there is a hemolysis. In what are the signs of hemolysis? Again, another question in hematology. I'll teach in exclusive hematology lecture. Increase in the retic count, increase in LDH, usually not mandatorily, increase indirect bilirubin, right? And what is decrease? Haptoglobulin is decrease. So these are the classical. So this is a classical, right? Classical is what retic count is increased, LDH is increased. They are not mentioned in direct bilirubin, but it increased. This is reduced. Urine 3 plus blood because of intravascular hemolysis, no RBC. And the biggest, most important, the golden line is absence of CD55 and 59 on the RBC. One more tips from my side today, if you have any scenario in your exam, it any MCQ comes and you don't understand. So it's possible sometimes we don't understand what exactly they are trying to tell. In that case, my experience is see only last two lines. You get some answer. Last two lines. Forget about first five, six, seven, 8 lines. See last two lines, right? So last two lines, there is a clue. Absence of CD55 and 59 in RBC and absence of CD59 and 55 on RBC by flow cytometry, it's a diagnosis of PNH. And this is a classical case of PNH, young male, female, pancytopenia, hemolysis, thrombosis, and absence of CD55 and 59 present on the surface of red blood cell is a diagnostic. So how you diagnose PNH? By only one test. One test is the name of this test is a flow cytometry, right? So flow cytometry. is the diagnostic test, and in the diagnostic test that confirm this is the RBC. On the RBC surface, there is a CD55 is there present in your RBC, my RBC present. This is CD59, right? And this can be detected surface marker by the test called as a flow cytometry or immunophenotyping by flow cytometry. Same thing, don't get confused. By that, you say you can get to know whether these surface proteins are present on the red blood cell or not. And when it is absent, this RBC get easily breaked, and that is why it develop the hemolysis. And because of hemolysis, this and this few clones are present on WBC platelet as well. So hemolysis, along with that, there is a low HB and low platelet, and diagnosed confirmatory test is a flow cytometry. And because of hemolysis, there is a elevated retic count and elevated RBC. And because of hemoglobin urea, there is a dark urine. And the treatment of choice is first we give the steroid to this patient, right? And another drug is also called as eculizumab. Eculizumab is a monoclonal antibody which reduces the thrombosis and hemolysis, right? But it will not completely cure the disease. It just reduces the these things. It will not do the change the pathophysiology, right? And it has a variable this course of the disease. Sometimes spontaneous remission can happen in some patient. I treated few patients of PNH, and we did one transplant, bone marrow transplant of PNH patients as well, right? So ultimately, eventual treatment is a bone marrow transplant, right? So 80 steroid is the initial treatment, and eculizumab, ATG, and cyclosporin is used for aplastic anemia. For your knowledge, cyclosporin again is a part of immunosuppressant. Cyclosporin drug, it's a aplastic anemia. Observation is not a treatment because you cannot observe at 7 grams of hemoglobin. You need to do something, otherwise it become 5. Patient is symptomatic. Patient is progressively fatigued. If they say this patient is absolutely 100% asymptomatic, then probably the observation is answered. In any symptomatic patient, irrespective of the diagnosis, you should treat the patient until and unless they are asymptomatic. Right? So diagnosis is PNH. How you investigate? By flow cytometry. Treatment is first treatment is steroids, eculizumab, third is bone marrow transplant. What is the best treatment? What is the only curative treatment options for this PNH? Bone marrow transplant. So steroid is a treatment, eculizumab monoclonal antibody to C5 that inhibits the activation of terminal complex. No need to go much in detail of pathophysiology. Allogenic bone marrow transplantation is the curative, is the only curative. Steroid is not curative, eculizumab not curative. It just reduces the risk, incidence and prevalence probably, I mean incidence of hemolysis and thrombosis. So this is the only condition where you get both the things at the same time, right? Thrombocytopenia plus thrombosis. So thrombocytopenia usually present with the bleeding, not the thrombosis, right? So here you can see the hemolysis and thrombosis. And sometimes I have seen few couple of patients, those who have mesenteric thrombosis, couple of patients have cerebrovascular as well. So it's a very rare disease, not very common in our clinical practice in hematology, but it is very important and frequently asked questions. And eculizumab is associated with Neisseria infection, right? And before this, they should get the vaccine. This is classical schematic presentation of these things. Probably you may not like this cartoon, but it's very important to me. That is why I posted here. So CD55, 59 is present normally in the normal red blood cell. What happens? There is a complement activation, right? And this all pathophysiology here, no hemolysis. But what happens in PNH RBC? PNH means the PNH clone where CD55 and 59 is absent. Here you cannot see this kind of picture, right? So means CD55, 59 is absent here. In that case, there is a normal physiology goes on, right? There is a complement activation. What because of this cell what gets break, and there is a intravascular hemolysis, and because of hemolysis there is a falling of fast HB, depends on the degree of hemolysis. That's it. So this is how it's work, right? So CD55 and 59 is important for our red blood cell. Clinical presentation: PNH acquired corpuscular hemolytic anemia, right? Acute and chronic hemolysis can develop, hemosiderin develop, iron deficiency because of hemoglobin is losing from the body, and hemoglobin losing means iron is losing. So this patient is classically hemolytic anemia, iron deficiency, and thrombosis. So atypical thrombosis, Budd-Chiari syndrome. Budd-Chiari syndrome is a portal vein thrombosis. It's also called as a, vessel, hepatic, sorry, arteries. Portal vein thrombosis, mesenteric thrombosis, cerebral thrombosis. I explained you bone marrow failure, right? And thrombocytopenia, anemia, leukopenia. Looks like aplastic anemia, but how you differentiate from acute leukemia and aplastic from PNH? On one is CD5, P2, 55 and 59 is normal in acute leukemia as well as in aplastic anemia, while in flow cytometry CD55, 59 is negative. In PNH, in PNH there is a, right, in PNH there is no blast, right? There is a no blast, while in acute leukemia there is a blast, and in aplastic anemia there is a severely hypocellular marrow, bone marrow, which is not the case. Here forming is well, bone marrow is making red blood cell, while in aplastic anemia bone marrow is not producing blood cell, right? And in PNH it's making. So what's the problem in PNH? PNH bone marrow is making proper hematopoiesis, but there destructions happen, right? While in aplastic anemia, A means absence and plasia means no formation. So there is no formation of blood cells from the bone marrow. That is the biggest problem. So it's a two different etiology. Iron deficiency, you can get low hemoglobin. Hemolytic, you can get low hemoglobin. But what is the difference in iron deficiency? Iron is not there to form the hemoglobin, while in hemolytic anemia, iron is there, blood is forming well, but in peripherally it gets breakdown. That's it. So both have anemia but have a different etiology. That's it. Open for question. Any question? Yeah, so I think many students had given the correct answer, so I appreciate their answer as well. So I think Dr. Amreen also given the correct answer, PNH, right? Dr. Bahar Toprak is also given the correct answer. So just, I'll try to make you a bit more in detail the explanation. Any questions with this? Any questions with this? Yes or no? Anyone?
No, sir. Very well explained. Thank you.
Wonderful, wonderful. No questions means we'll go ahead. Now you check. These all questions are different department. Let me remind you, right? So see, first questions, markers is cardiac questions. Second questions, GI questions, intestinal obstructions. Third questions is little infectious disease, Yersinia, rehash. This is again hematology, so all different questions. Now again, this is different question. Now your knowledge of endocrine come anti-diabetic drug. So I selected all questions like exam. DPP4 inhibitors, how does it work? So first of all, somebody has to give me the full form of DPP4 inhibitor. Second thing is, what is DPP4 inhibitor? And then this question comes, how does it works, the DPP4 inhibitors? Anyone? You read the question. So DPP4 inhibitor, how does it work? Enhance the peripheral insulin sensitivity and inhibits the gluconeogenesis in the liver. Second, insulin secretagogue. Third is the activation of PAP-RY to promote the glucose utilization and reduce insulin resistance. D is promote insulin secretion and decrease
Sir,
glucagon secretion. Yes.
sir,
So
it
these are
is
the
it's oral hypoglycemic and
wonderful. So this is oral hypoglycemic, number one. So anti-diabetic drug, wonderful. Second thing
yes,
is the full form of DPP.
dipeptidase.
Yes.
Yeah, it's dipeptidase, something like
This
that.
is
It's work on a
by
protein.
this is by mistake. This is DPP4.
Dipeptidase
Yeah,
4
dipeptidase.
inhibitors.
Yes,
Okay. Now the
yes.
next question, one by one. What do you think? How the DPP4 inhibitors works in the body? So once you take the DPP4 inhibitor, right, it goes to the mouth, to the stomach, intestine, it get absorbed, and where it acts on the liver, on the pancreas, on the intestine, on the periphery, and how does it reduces the blood sugar basically? That is bottom line. It's anti-diabetic, right? So how does it reduces the drug? A, B, C, or D? Or none of the above? It could be possible that it acts in a different way, which is not mentioned
It's
here.
it work on a beta cell. It It work on a beta cell of pancreas, I think.
Okay, so what's the answer? In the exam, if the same question will come, what will you take? A, B, C, D, or E? You have only one option to tick. What will you tick? So today's homework, today's 1 in 5 people across the globe is suffering from diabetes. So Middle East country, USA, UK, I've been there, now in Dubai, India. Everybody has one patient in their family. Everybody has one patient, father, mother, grandfather, daughter, whatever. I mean, so much diabetes. So you must know, not this question, you should know at least three things. You know how metformin works, how sulfonylurea works, how DPP4 inhibitor works, how SGL1 inhibitor works, how insulin works. Everything you should know. This is your homework today, Sunday.
Uh, it's not a first line medicine giving in like type 2 diabetes. It's not the first line. That is what I know.
So what is the first
But
line then?
how it works?
Which one is the first line? This is not the first line, means something is first. Yes, Dania. What is the first line
Sir,
then?
yes, sir, I'm Dr. Ali. I'm ID, sorry.
Your name is showing as a Dania,
It's
so
like
I'm every time telling you Dania.
yeah, because my daughter uses it for school. Sir, the first line is sir, the
What is
first
the
line is
first line?
sulfonylurea.
Not at all. Sulfonylurea is not a first line treatment. Metformin is the first line treatment for any diabetic type 2. Anyone wants to try this questions? I think you are tired. Yes, anyone? We are many people and just answer is 3 in the
Sir, I
chat.
think
Yeah, you try because in the exam you must
sir,
have to try. There is no Dr. Munjal Pandya who can break the questions for you. You only have to dissect the question,
sir,
try
it
to
inhibits
understand.
GLP-1.
Sorry?
Inhibits GLP-1
Inhibit
receptors.
GLP-1. Okay. So where is this GLP-1 situated? Pancreas, liver, intestine. What is the full form of GLP-1? So
Glucagon-like peptide.
Glucagon-like peptide.
I request each and every doctor, whether they knows or they don't know, read the chapter of anti-diabetic drug. This is the chart, excellent. I got it for you guys. Type 2 diabetes, first line is a lifestyle modification, and exercise is a cornerstone of any diabetic management. And the big one, it's metformin, first line, it is written already here, right? How it works, it enhances the peripheral insulin sensitivity and inhibits the gluconeogenesis in the liver. So biguanide or metformin, group of the drug is biguanide, but the brand is a metformin. I mean, how we know metformin. So why the metformin is first line so popular? Because it does not act on the insulin. It is not doing release of insulin. What it does, it enhance the peripheral insulin sensitivity, means whatever the insulin is there, make it sensitive to work better and inhibit the glucose formation in the liver, and that is why the hypoglycemia is not a side effect in metformin. Metformin patient doesn't comes to you in emergency with hypoglycemia. Sulfonylurea comes. Why? Metformin does not act directly on the insulin release, while sulfonylurea directly acts on the beta cell, directly acts on the insulin secretogenic. It directly acts the insulin to act faster, release it. And that is why if you don't eat on time, you may have hypoglycemia, right? Which is not the case with metformin. And it is very important in elderly patients, right? Where you have hypoglycemia, they have coma, they have seizures, they may die, they may fall. So metformin is a first line treatment. It acts by this way, and sulfonylurea acts by insulin secretogenous, or what? It directly, once you take oral tablet, it directly act on the pancreas. It try to stimulate the beta cell. It releases the insulin. That is why it is a insulin secretogenous. That's it. So this is what the logic is, right? And same way you need to know all the things. There are not a long list, right? But you must know basic things. So DPP4 inhibitor, the sitagliptin, wherever the gliptin is comes, sitagliptin, vildagliptin, hexagliptin, right? So this all gliptin family is DDP4 inhibitor. What is the action? Promote the insulin secretion and decrease the glucagon secretion via inhibition of glucose like peptide 1 degradation. So this is excellent schematic chart. I took it for you. What happens when you ingest the food? It promotes the glucagon like peptide GLP, glucagon like peptide release. What this does, GLP-1, this release, GLP-1 gets activated, right? And this all will happen. What happens in the DPP4 inhibitor, when you give DPP4 inhibitors, it blocks this, and because of blocking this will helps to control the diabetes. What it does, increase the endogenous GLP-1, decrease glucagon secretion, decrease hepatic glucose output, and increase insulin release. So this is how it works. This is DPP4 inhibitor, and this is GLP-1, right? So it's a very important things you must know, right? So you need to know each and every basic. At least you should know three by my knowledge and experience. Metformin, how does it work? They frequently ask. Sulfonylurea, how it does work, right? And DPP4 inhibitor, how does it work? And little side effects are also there, little important, right? So you must know that as well. So this 2 page, I think you need to mug up for your own clinical patients, for your own improvement of knowledge, as well as for exam perspective as well, right? So this is
But
how the
nowadays, it is combined with the like Begunite. It's happening, right?
yes, it is a combination of drugs with the
Yeah.
metformin is commonly available with the
With sitagliptin and like this.
sitagliptin, vildagliptin, hexagliptin, tenagliptin. There are a lot of drugs comes
Mhm.
in the market in the last few years, right? But you should know
Yes.
at least the basic things. So this is the completely nice example of drug mechanism of action. High yield effect means it's the general side effects. That's it. So you must know. So what's the answer of this? So answer of this is promote the insulin secretion
Yes.
and decrease the glucagon secretion of GLP-1, right? Enhance the peripheral insulin sensitivity and reduce. This is metformin. This is sulfonylurea, right? Just for your knowledge. And this is thiazolidinedione. This is all the drug side effect is given here. Okay. So you must know this all things, right? So this is thiazolidinedione's activation of
I do this one.
PRP, promote the glucose utilization and reduce insulin resistance. This is how it works,
Also,
right? So yeah, so first one is a metformin, second one is a sulfonylurea, this is thiazolidinedione, and this is the DDP4 inhibitor. And this is not the answer, none of above, answer is D. That's all for more couple of questions I'll cover. Are you okay or hungry?
Sir, can I ask you a doubt, sir?
Yes, please. Always open.
Sir, in a case of GDM, diabetes mellitus in
Gestational diabetes
pregnancy.
mellitus. Yes.
Yes, sir. Yes, sir. First line treatment is exercise or diet advice. After that, what is the treatment, sir? Is it metformin or insulin?
Depends on, the answer is
usually
little
insulin.
tricky, but I'll
So
try
because
my level best.
different literature says,
Yeah. So
sir,
say for
different
example,
literature says different answers. So for
sorry,
exam
literature says what?
purpose, which answer? Sir,
Literature says
I saw one in one metformin and another one I saw we have to start insulin. If the patient is not ready to start insulin only, we'll go for metformin. So,
Fine.
for exam purpose, which answer is correct, sir?
Insulin is the correct answer, doctor. Insulin, right?
Okay, sir.
But as you rightly
Okay.
said, I will
Okay.
also confirm with my gynecologist. We have two gynecologists in our coaching team. One is Dr. Shikha and another is Dr. Deepali. We discuss the same thing, but nowadays metformin is also approved and it is used in the pregnancy for gestational diabetes because it increases the sensitivity of the insulin and which is the most important problem in gestational diabetes. So metformin is again used it, right? But severe case, if you have the option, answer insulin. That is the most proven answer. You got it?
Okay, sir. Okay. Thank you so
Yeah.
much.
So uh, last couple of questions. A 37-year-old woman present with her physician with 3 days of fever, fatigue, rash. Her medication includes oral contraceptives. Her temperature is 101.7 Fahrenheit. She also has a non-palpable petechial rash and splenomegaly. Coagulation studies and fibrinogen levels are normal, but a complete blood count shows a hemoglobin level of 9.7, platelet is 135,000, peripheral smear shows cystocyte. Which of the following is most likely diagnosis? Is it disseminated
ITP.
intravascular coagulation, HELP syndrome, Enos Collin purpura, idiopathic thrombocytopenic purpura, right? And thrombotic thrombocytopenic purpura. I muted all because a lot of disturbance in the background with the patients. So those who wants to answer, they can post the things.
It's showing like a schistocytes. Schistocytes are there, so it could be the hemolytic in origin.
So what's the answer? Once you give the answer, we'll start discussion. Sorry.
Said between D and E, either the idiopathic, the cause is unknown.
Select one, my sister, select one. You cannot select two in exam. Select one. We'll discuss. It's a learning platform. We'll discuss, but select one. Take your time. I'm not telling you to make hurry. Read it once more questions. Take your more 30-second, 1 minute. Yes, Miller. How you explain the ITP? Let's start with you. Probably the last questions for day. Yes, Miller.
I would say the platelet as well as anemia corresponds with it.
Sorry. So your answer is ITP, right? If I'm not wrong.
ITP.
ITP. Okay, fine. So what point favoring ITP and what point not favoring the ITP? Tell me, Miller.
Yeah,
Favoring would
ITP.
be anemia, thrombocytopenia,
So
petechial rash.
only one question, Miller, if I can ask you, right?
Yeah.
That could you see temperature or fever in ITP usually?
Is TTP. Is TTP has five pentad symptoms: thrombocytopenia, schistosis, fever, neurologic symptoms, and um, renal symptoms. Is TTP.
Yeah, that's correct. So what's the answer again? Finally, my question is that is what's the answer?
I swear, I think it's TTP.
TTP.
Yeah,
Okay.
actually, because
Let's see.
ITP has yes thrombocytopenia, but the most symptoms is petechiae, purpura, mucosal bleeding, but no schistosis and hemolytic anemia in ITP. Due to it is in TTP.
Okay. So let's see. I mean, just wait for 1 minute. What other experts are saying, so we can go ahead. Let them think, brainstorm little things. try to open up their brain. Cannot see the screen, sir. Okay, 1 minute. I'm also trying to. What happened? One second. Can you see now?
Yes, sir.
Yeah. So anyone wants to try? Dr. Bahar Toprak has given her this opinion that she looks like a TTP. So what other opinion in
And
the
I want to
house?
say another feature. ITP has normal hemoglobin, low hemoglobin level is the dissemination.
Okay. Anyone? Only just one candidate, Dr. Toprak only, Bahar. Now everyone can see the screen. Few comments were cannot see the screen. Now you can
Sir,
see the
but
screen.
sir, but in TTP, as she said,
No, I did not say it. Dr. Bahar Toprak said. I will discuss and I'll come
yes,
to the
yes, as
conclusion.
she said, that's why I said, because in the TTP there is a one Willy branch factors deficiency or absence, or it may be like from the congenital. So why it's showing so late?
So what's the answer? First of all, tell your
Are
answer.
you getting my point?
So tell me first the answer. What is the answer? Then we'll discuss. One answer from Toprak Bahar is TTP. Miller is saying ITP. I'm not. I'm saying ITP is not there because ITP is not there because I have strong reason. Whatever I am telling, I have a reason, right? So I have a reason of not ITP is usually ITP, uh, right? Here something temperature is against, and this is quite high temperature. Second thing is in ITP, you cannot see the hemoglobin low. Number two. Number three, in ITP, you never ever see a cystocyte. Cystocyte is a broken RBC.
Cystocyte.
RBC is a dumbbell shape. Normal, the shape of RBC is a dumbbell shape. This is normal RBC. Cystocyte is a broken RBC. If you cut the RBC, it's a broken RBC like this. Broken RBC. So it is never ever seen in ITP. Never ever. Cystocyte means some kind of hemolysis, septicemia, DIC, bone marrow is at stress, right? Or drug induced or G6PD deficiency or something where you see the cystocyte. You cannot see the cystocyte in ITP. So your homework, Miller, is to go and read the ITP and discuss with me tomorrow.
Yes, sir.
Right? Anyone else? So now, as the Bahar Toprak told, it's a correct answer is TTP. Let me tell you one by one, and I want to teach you one excellent things here. The five things here, right? Disseminated intravascular coagulation. That is shortly called as a DIC. What is the classical presentation of DIC? Fever they have low platelet or thrombocytopenia. They have high PT and APTT because consumptive coagulopathy. So not only platelets are consumed, factors are also consumed. So here no PT, APTT is raised. PT and APTT is usually not raised. They are normal, right? So if it is a TTP, they have given something like that, right? That they have this blah blah blah. and also the fibrinogen is also low, which is normal here. If you can see, coagulation study and fibrinogen levels are normal, means it is not a DIC, because in DIC, coagulation means PT, APTT should be raised and fibrinogen should be low. That's it. This is how we have to understand. So it is not there. So DIC is gone. I give you the reason. HELP, full form of HELP is hemolysis, elevated liver, and low platelet syndrome. It is usually seen in a pregnant patient, hypertensive patients, pre-eclamptic kind of pictures with proteinuria, hypertension. So hemolysis, cystocyte is there, low HB is there. But do you have elevated liver? EL, hemolysis is one, it is there, but elevated liver, it is there. Elevated liver, no elevated liver, and low platelet is there, right? So low platelet and hemolysis is there, but no elevation of liver enzyme. Patient is not a pregnant, right? Patient does not have any hypertension, so it does not fit the HELP syndrome. HSP, Henox choline purpura, it's a vasculitis. The biggest point against this HSP is HSP platelets are normal. For your knowledge, there is a pataky, but platelets are normal. It's a vasculitis, autoimmune disease. It is not a hematological disease. So platelets are normal and hemoglobin is also normal. So here hemoglobin is low, platelets are also low, right? So this is not HSP. ITP, why it is not ITP? Because ITP only low platelet counts are there, right? Hemoglobin should be normal, which is not there. And you never ever see cystocytes in the peripheral blood. So what's remaining is a TTP. Let me tell you the TTP. Right? So let me tell you the TTP. So TTP is what? Basically, you must have heard, but you probably not seen any patient, because I also seen only one or two patient in my 20 years of practice. But it's an interesting disease to know. TTP is the thrombotic thrombocytopenic. See the controversy. One side I'm saying thrombosis, and here I'm saying thrombocytopenia. So how come this thrombocytopenia patient develop thrombosis? But this is the name, TTP. What is the difference between TTP and HUS? That is again another question in exam. We are confused every time. So it is a problem in Adams 13 kind of enzyme. Go and read TTP, interesting topic. Basic. I don't want you to do research in Adams 13. Just basic
Sir,
topic cover.
won't believe in factor, right?
No, it is a different doctor.
Won't believe in.
Adams 13. The factor which is deficient or mutated is Adams 30. This is infection, usually E. coli infection preceded by the things. This is usually seen in a children. This is usually seen in an adult. Three things are common in both the things: thrombotic thrombocytopenic purpura, microangiopathic hemolytic anemia. MAHA, somebody has written MAHA, right? So here you get a low hemoglobin, you get low platelet, you get increased creatinine. Here low hemoglobin, low platelet, increased creatinine. Both are same thing in both. Then how you differentiate? This is triad. Triad, three things. This is pentad, five things. Pentad, five things. These three plus fever plus neurological involvement. This is the beauty of these things. Our patient has fever. Our patient has low hemoglobin of 9.7. Our patient has a low platelet. Because of microangiopathic hemolytic anemia, they have a cystocyte. They have a fever. One of pentad is a fever. So this is classically fitting the thrombotic thrombocytopenic purpura. Now, if you go back the scenario, now everything is matching this. This is what you need to do a practice in your preparation. When you are preparing, I mean, solving the any MCQ, you need to retrospectively think. You answered ITP, not just for Miller, in general, I'm telling you. So you answered the ITP, but you have to think, can, can low hemoglobin happens in ITP? Can cystocyte be seen in a ITP? No, then it is not the answer. Now, You don't just need to, whenever you confirm your one answer, say for example, here I confirm this answer, then I have to look everything what happens in TTP, whether it is there. Let's see, it is seen usual in female. This is the adult age. I told you, fever is one of the pentad. Yes, right? Coagulation profile, and this is normal. Yes, it is normal. Anemia is there. Yes, it is there. Thrombocytopenia is there. Yes, because of microangiopathic hemolytic anemia, cystocyte is there. Yes. And if the any 1 minute, and if this patient somebody says there is a neurological involvement or seizure, also there, it is there. It is a part of pentad. Is that clear? So you need to see all the clinical data in the scenario to give your answer. You can't just give, okay, low platelet ITP. Cannot, I mean, this, the way I'm giving you the technique is a sure shot. I mean, there are high chance that you will not end up with the wrong answer. There are high chance that you end up with the right answer. Why? Because you are seeing the all clinical this scenarios and vignity as a whole, right? So that's it for all today. I guess we are. This is
So
what the
why
thing
they
is.
saying the oral contraceptive? Is it any important? What the clue they are giving us?
Importance of oral contraceptive is again the thrombosis, doctor. Any oral contraceptive pills, it increases the risk of thrombosis. So that's it, nothing otherwise much. And this is TTP versus HUS. I told you already, hemolytic uremic syndrome is HUS and TTP. Here the E. coli mainly, the patient present with the diarrhea, vomiting, usually in the children, here is in the adult. E. coli, this is Adams 13 gene mutation. Because of that, this all pathophysiology happen. Three things I told you common, right? Anemia, thrombocytopenia, renal death, I mean, increased creatinine, both. But here the pentad is fever and neurological. So, three, what three? Anemia, thrombocytopenia, high creatinine, common in both the things. But here, two additional things, fever plus neurological symptoms, 90% mortality. And this is sick, only just 10%. So, prognostically, if you have TTP, very bad disease, you have 90% chance that you may lose the patient. We had one patient of, they presented with two things only, let me tell you. And in pentad, you don't need to have all pentad, all five to diagnose TTP. At least if you have three, four features, you can diagnose. And eventually, you need to send a sample for Adams 13 gene mutation. If it is positive, it's TTP, right? So, our patient has a fever as well as neurological things, both along with the low platelet. So we thought of TTP, we did Adams 13s in our patient, and it was positive, fortunately, and fortunately we could able to save the patient. That's the beauty, right? So this is the classical pentad, thrombocytopenia, microangiopathic, hemolytic anemia, MAHA, mental status changes or neurological things, fever, renal failure, right? And at least you need at least three, right, to confirm the diagnosis. And HSP, as I told you, it's a vasculitis. Platelets are normal here. The low, it is an ITP, only low platelet. Hemoglobin should be normal and there should no be cystocyte. That's it. That's all for today. I'll just have a quick feedback. Somebody, if can give the feedback of my lecture, I would be glad and happy. And what you have learned new little bit so far. Something is there always in every lecture to learn. This is what I feel, right? Because if I listen anybody's lecture, I have something to learn in anybody's lecture. So hopefully you have the same thing in your today's sessions as well. Anyone wants to have a little quick
No, sir,
feedback
the
on the
great.
lecture?
Sir, great. And always knowledgeable. It's a very knowledge
Wonderful,
gaining lecture.
wonderful. Thank you very much for your kind feedback.
Yes, sir. Thank you
Wonderful.
so very much. Very well explained all the classes. Even in a few questions, you have covered so many topics from different systems. It's like
Wonderful.
a whole plate cocktail like that.
Thank you very much for
Yes,
your kind
absolutely.
feedback.
She said absolutely.
Wonderful, wonderful. Anyone last?
Sir, I think the best way, I think you taught me from my mistakes is to rule out each option rather than
Okay.
to point out or be narrow-sighted in some evidence to support your answer. I
Wonderful.
think that was
So probably what this is what I mean, I did not read it from any book, but this is my style of treating the patient. So I try to, I mean, interpret the things and I try to implement and I try to come to the diagnosis and then treatment. You understand? So this is a practical way basically, right? When we solve anything, I mean, we don't need to just focus on the answer, but why this not, why this not, why this not? This is absolutely analytic skill, probably comes from the clinical experience. I'm not speaking in front of you just with the, I mean, graduated yesterday. It took 20 years for me to reach here to explain this. But I mean, you make a habit. You all are young, energetic, brilliant doctors. I'm proud of all of you, but try to involve more in a clinical things, right? Try to understand the things that how it's going to happen. So once you understand the things, it's easy for you to answer any question in your exam, right? Thank you very much. And one more announcement before you leave: those who are in Dubai, they can join for tea coffee. I will not ask any MCQ in tea coffee table. So those who are in Dubai or Sharjah nearby, they can join today evening. I will be here. We are meeting. I posted in the group. Anybody need any help, they can call me on the same number direct. It's in roaming, so they can trace me on the same number, right? So we'll wait for you. And thank you very much once again. We'll continue the sessions on next Sunday as well. Though I'm in Dubai, I will again try to take this lecture, right? Thank you very much. Thank you.